Connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. It's a service to our members, strategic partners, and the child health research community. I'm Paula Robeson, your host for the next hour. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health and healthcare from coast to coast to coast. We're delighted today to speak with colleagues from Project ECHO Network, Dr. Melanie Penner, Maddie Dever, and Munira Kilji about quality community-based autism care in Canada, scaling up ECHO AuDIO. Dr. Melanie Penner is a developmental pediatrician and a senior clinical scientist at Holland Bloorview Kids Rehabilitation Hospital in Toronto. She has done research and educational work to expand Ontario's diagnostic capacity for autism diagnoses in the community setting, decreasing wait times and facilitating earlier access to essential intervention programs. Dr. Penner leads the ECHO AuDIO study, which aims to spread and scale ECHO autism across multiple sites in Canada. Maddie Dever is a non-binary wheelchair user with a spinal cord injury and an autistic adult and parent of 4 children who are all also autistic. Living in rural and Eastern Ontario in Canada, Maddie advocates with both provincial and federal governments for inclusion and acceptance of autistic individuals and for autistic people and all people with disabilities to have their own voice in policy decisions. Maddie is a writer, speaker, podcaster, and former member of the Ontario Autism Program Advisory Panel and the Ontario Autism Implementation Working Group. He's president and founder of the Autistic Bridge Incorporated and co-vice chair of the Autism Alliance of Canada, an expert hub team member for ECHO Ontario Autism, ECHO Ontario Brain Health, and Family ECHO US, and is an autistic advocate and executive team member of the Autism Care Network in the US and director of policy for Ontario Disability Coalition. Munira Kilji is the manager of the Entry to School and Case Management programs at the South Asian Autism Awareness Center. Her training as a healthcare professional, experiences as the parent of 2, and insights as an advocate for health equity in underserved communities deeply informs the initiatives Munira supports. During the past 10 years, Munira has championed the need for better support and services for families on the autism spectrum. And she started off with a community-led Thorncliffe Collaborative for Muslim families that enabled parents to engage in training opportunities that were accessible and culturally sensitive. She then garnered experience in cross-sectoral partnerships and integrated healthcare pathways through her work coordinating a school-based pediatric clinic for health access, Thorncliffe Park, that focuses on supporting children and youth who experience challenges with learning, growth, behavior, and/or development. Currently, Munira supports the ministry-led programming at the South Asian Autism Awareness Center. And the full speaker bios can be found online on Children's Healthcare Canada. So over to the speakers. Welcome all, and it's now my pleasure to pass the mic to Melanie Penner.
Hi, everyone. Thank you so much for coming. Don't I have some cool friends? It's pretty amazing to hear their bios. So I'll just pull up my slides. Okay, I'm hoping I'm sharing the right thing. Maddie's giving me a nod. Okay, two screens is always an adventure for this. So today we're excited to share with you some work that we're doing, and work that we're doing to improve community-based care in Canada for autistic children and their families. And so part of this is describing to you what our ECHO Autism program is, and part of this is describing what our kind of big implementation study called ECHO AuDIO is. So we've had a land acknowledgement. We are all, if you're joining from Canada, coming to this from Turtle Island, and I am on Treaty 13 land in Toronto with the Mississaugas of the Credit. And if you are probably somewhere within healthcare in coming to this, and truth and reconciliation makes us have to recognize the systems that we're in have been built upon harms. And when we look toward a way forward, this picture of Turtle Island by Jeffrey George has these 7 trees which represent the 7 grandfather teachings given by the Creator. And I think these are good values that we can use to decolonize and reimagine our healthcare system. So truth, honesty, bravery, respect, humility, wisdom, and love. So hopefully that can inspire us for our discussion today. Today's objectives. I am hoping we can discuss the need for high quality community-based autism care. I want us to understand how implementation science approaches can help to spread and scale promising programs. And this has been a new learning for me as a clinician, as a scientist, in terms of the value of using these approaches. And then I think most importantly, I want to get out of the way and let you hear from the lived experience voices about how they want to reimagine autism care in Canada and why it's important to do that. So you're probably not going to be shocked by the next couple of slides, but probably still also disappointed, right? So we know autism wait times. Wait times are probably the main thing we talk about, honestly, when we talk about autism. And so this is from Ontario in the news quite recently. More than 6,000 kids waiting for autism assessments, and that data had to be accessed through a Freedom of Information request. Not just Ontario, this is from Saskatchewan, and they had more than 1,700 kids waiting. So this is very real to me as someone who does autism diagnostic assessments clinically. And when I was doing my training, I started to think about, whether kids actually had to wait to see me as a subspecialist, and whether some of them could be seen in the community for their diagnosis instead. And this led me down a whole career pathway that I don't think I could have ever anticipated. I did a survey of Canadian pediatricians looking at whether they diagnose autism in their practices. This was now published a long time ago, 2017. At that time, the wait time that people reported was about 7 months. It is much longer now, given all of the effects of the pandemic. People used a variety of different team structures, tools to diagnose autism. We did find that solo pediatricians in the community were diagnosing autism. And then there's this finding that seemed to, be something that needed to be said out loud, that the longer you spend assessing each kid, the longer your reported wait times are. And so we need to make really careful decisions when we're deciding what needs to be part of an autism diagnostic assessment. I also did some qualitative work. I interviewed general pediatricians about whether they diagnosed autism or not, and what influenced those decisions. And what they told me, again, maybe wasn't non-obvious in some ways, but I think is one of these things that needed to be said out loud. So pediatricians felt like, sure, they could have some challenges in determining the diagnosis sometimes, but there were other times where they could absolutely determine that the child was autistic, but they experienced barriers in telling the family that diagnosis and in knowing what to do next. And all of this sort of exists in this system where we've got kids, we've got families with their own kind of situations and expectations. We've got the pediatrician, their training, their peers, their their scope of practice, and then we've got this broader system. And I will tell you that of all the studies I've done, this one has directly impacted a lot of what I'm going to tell you about in terms of how we designed our ECHO Autism program to try to directly address these things that pediatricians told us. Of course, there's the issue of whether they can actually do this accurately. So we spent a number of years doing a study about how accurate general pediatricians were when they assessed for autism. And there's a QR code. That one has been published now, and I'll show you the results. So for those of you, if there's anyone out there like me who is an absolute nerd for a 2x2 diagnostic test table, this is for you. Otherwise, I'll take you through it. So we had a lot of kids in our sample where the pediatrician assessed and thought the child was autistic, and our multidisciplinary team assessed and also thought the child was autistic. This is great news. The not so great news about this is that when the pediatrician thought the child was not autistic, there were kind of an uncomfortable number of those cases where our expert team thought that actually the child was autistic. So some of these, we would call them false negative cases. So this kind of gets summarized into our positive predictive value. So when a pediatrician thought the child was autistic, we agreed with them almost 90% of the time. When a pediatrician didn't think the child was autistic, however, we only agreed with them about 60% of the time. What is, I think, really interesting about this is that our system is a bit the other way in terms of this. Pediatricians often feel like it's within their scope of practice to rule out autism, and yet ruling it in or making that diagnosis seems to be the new thing that we're asking them to do. So this is part of the system shift that we're trying to enact based on this evidence. So what is ECHO? ECHO stands for Extension of Community Healthcare Outcomes. And it began in a very different place for a very different purpose. So it began in New Mexico with a doctor who was seeing that his patients who lived in rural areas who had hepatitis C were not having the same outcomes as his patients in urban areas. And so he developed this program that aims to train up providers and create a community of practice of people who are interested in providing good care in that particular area. So we have adapted this for autism. Actually, a colleague of ours, Kristen Soul in the States, was the first person to adapt this for autism, and we are certainly blessed to be making use of some of those innovations that she made and making it fit the Canadian context. So our session structure, we do this on Zoom every 1 to 2 weeks. This is our hub team. We had our hub team meeting yesterday, so this is a very fresh picture. We have a physician, psychologist, occupational therapist, board certified behavior analyst, social worker, we have an autistic advocate who might look familiar, and we have a family leader as well. Every session has to follow the ECHO model. So when we talk about ECHO as an evidence-based practice, it is this structure that you have to kind of adhere to. So we do introductions every time, and that's really important for us to build a sense of community. There's a didactic presentation, we have a curriculum. So that day might be talking about, say, like autism and puberty. We have case discussions, and that is supposed to be really the bulk of where the learning comes from. And the case discussions are brought by community-based participants in their practice, not from me in my sort of ivory tower practice. We really encourage our community participants to be the first ones to ask clarifying questions and to provide recommendations. Again, I think this is how the ECHO model works to create a community of practice. And then we distribute all of our resources and slides and recommendations to everyone afterward. So we've got this great program in Ontario called ECHO Autism. It's thriving, and it's time to spread and scale that work. And so this is what we're calling ECHO AuDIO. Project ECHO AuDIO. AuDIO here stands for Autism Diagnosis and Integrated Care Opportunities. I love a good acronym. So once I had the acronym, I was like, okay, well, it's time to do the study then. So this is a 5-year study that has been funded through the Canadian Institutes of Health Research, or CIHR. And it was funded through a specific program that they have called Transforming Health Through Integrated Care. And part of this was to use implementation science methods, which we'll talk about, to spread and scale things that are working in one place and to try to get them working in multiple places. So we have 5 sites across Canada. We have us in Ontario. I'll talk about Alberta first. So Edmonton has an ECHO Autism program that's been running for a number of years now. In Quebec, in Montreal, they have one that's been running for a few years. A newly launched one in Halifax, which is so exciting. And then we are hoping to get one off the ground in Vancouver and BC as well. And we want to integrate 2 key elements of autism care here. So I've talked a lot about diagnosis, and I do think diagnosis is such a critical thing to build into this. And we know autistic people exist after their diagnosis, and so we need to continue to provide ongoing care. And so these are the 2 things that we're hoping to work into this program. So why implementation science? This is like, I am a bit of a convert on this. You know, I think it can be easy for us to look at our own programs and think about the fact that, like, we know what makes this work. Or we can kind of figure out, well, we'll make it work somewhere else. And I think I've really come to see the value of using some of these implementation science frameworks to make me think, like, systematically through all of the factors that we need to think about through spreading something to a different location, understanding what's going to make it work and what can get in the way. There are implementation process theories that help us to understand the how are we going to do this? How do we know what needs to be done? How do we know what we need to keep the same about this intervention? And how do we know what we need to adapt about this intervention? And then we have evaluation frameworks, and those tell us, how do we know that we actually did what we thought we were going to do? And we're trying to build both of these into the plan for this program. So our overall strategy, and I'm coming here and I want to say this publicly because I want to come back to you and to share the results of this as we go. And I think, you know, we're receiving public research dollars, and that means we're accountable to the public to be sharing our results. So we are currently in the midst of doing lots of interviews to develop toolkits to help with autism diagnosis and with ongoing integrated care. We're going to develop the strategies to implement those toolkits, right? Thinking about the process of implementation. And then we're going to measure to see, did we actually move the needle on autism care in Canada, which feels really ambitious, but thankfully I've got a good team with me. This is a really busy slide, but this is the details of how we're going to do it. So we have a framework, the theoretical domains framework. I'll give you the inside scoop on that in a minute. Our first step is to do interviews and focus groups with community-based pediatricians and other healthcare providers to understand their on-the-ground experience of trying to deliver this care. We're going to take those themes and those quotes to give us that really rich understanding, and then start to develop the toolkits for them to implement as part of their practice and in conjunction with the teaching and case discussion that they get through the ECHO program. We're going to work to implement those things. We're going to think about what needs to stay the same and what needs to be adapted to represent the realities of delivering care in Nova Scotia versus British Columbia. And then in our final stages, we're going to use an implementation framework to evaluate it all, and then share the results back with toolkits, a town hall, a launch kit for places considering ECHO programs. So we'll have a lot of work to do at that stage as well. This is the theoretical domains framework, and the webinar will be posted. And if you want, you can take a gander at this. But this is a really great way to understand why people do the things that they do in clinical practice and elsewhere. So there are a lot of psychological theories sort of built into it, and 14 domains overall. So we can see some of them here. So knowledge. Providers, does the provider think that they have the skills to deliver the thing that you're asking them to do? How do they see it within their social role and identity? What are their beliefs about their capabilities? And do they feel optimistic about it? What is their level of motivation? Each of these has strategies that can be mapped to it, which is so cool. And then we can really start to build a tailored approach to help make our implementation successful. And then these are the things we want to measure at the end. So, was this acceptable? Do people want to do the thing that we're asking them to do? Did they actually do it? Is adoption. We want to think about the costs. We want to think about whether they see it as being reasonable or feasible to implement in their practice. How far did we get, or the penetration? So how many people have adopted these new kind of best practices in autism care? And then finally, and maybe not finally, because I think we should be thinking about this from the beginning, are these new practices that we've asked them to do sustainable? Is this going to look the same years from now in terms of what we're asking them to do? So thank you for bearing with me as a convert to the benefits of implementation science, and how we're hoping to be successful in these big aims that we have. I want to shift gears and talk about what one of the kind of foundational elements of this whole endeavor. So we have two councils who are guiding the work that we do, and they are guiding the ways that we're asking questions. They are guiding the ways that we are analyzing our results. So one council is of autistic folks who too long have been left out of the discussion about their care. And one council is from folks from equity deserving groups, similarly, who have not been invited to the table to help design care. We want them to not only consult on our study processes, but also to consult on the ECHO content, So what are we teaching community doctors and nurse practitioners? Help us identify other things that we need to review that are relevant to care for autistic children in the community, and lots of room really and latitude to come up with new projects or ideas to improve healthcare for autistic children and youth. And with that, I'm so happy to stop talking and to turn it over to Maddie, who's going to talk to us about the autistic voice in all of this.
Oh, thank you, Mel. My name is Maddie Dever, and I am autistic. I am non-binary, and I use they, them pronouns. I'm a parent of 4 kids who are all also autistic. I'm diabetic. I'm a wheelchair user due to spinal cord injury. I am white with long brown hair. I wear glasses. I don't actually wear glasses anymore. I am sitting in a wide brown chair. I'm a Sens hockey fan. Sorry about that, Leafs fan, and I'm Canadian. I live in rural Eastern Ontario in the traditional territory of the Anishinaabe, Huron-Wendat, and the Haudenosaunee peoples. This people is covered by the Upper Canada Treaty. So, next slide. Way back in 2020, I was chosen to be part of the Ontario Autism Program's implementation working group as a link to being one of the 2 autistic members of the OAP advisory panel that issued their report with recommendations for changes to the Ontario Autism Program in 2019. And it was so good to see Dr. Jessica Bryan from Holland Bloorview again, as we had both served on that panel. Someone else new, however, who I really clicked with immediately was our illustrious leader, Dr. Melanie Penner. We had so many conversations about neurodivergence, autism acceptance, and shifting clinicians towards a more strength-based way of supporting autistics and their families. Well, one of the first things that she recruited me to do at the beginning of a great relationship of joint things was to do a joint presentation that summer on the language of autism acceptance. And that ECHO Summer pop-up session kicked off an incredible set of opportunities, but the biggest was being invited to be a member of their ECHO Autism's expert hub team. And what I really loved and appreciated was that Holland Bloorview was working on walking the walk about patient and family-centered care by including at the table both family members and autistics. And being part of this team, this family, has been one of the richest experiences of my life. Next slide. When I began participating in ECHO Autism as an expert hub member back in 2020, I really didn't know how it worked and what to expect. I'm used to giving presentations and leading workshops where there's a Q&A after the talk. ECHO is different in that there's first a didactic part where there's a presentation followed by a QA, but then there's a case brought by one of the community participants. And as much as I consider myself well-read and full of my own lived experience as both an autistic adult and a parent of 4 autistic kids, I learned so many new things from these didactics. Every session, I gleaned something new, but it also triggered different things from my own experience that I would at times would like to add on to. And doing these sessions through Zoom allows the ability to participate both on screen and in chat. And for many autistics, it is preferred to use the chat function to be able to get our words out in a way that we can curate saying what we might be unable to say verbally. And I do experience it sometimes. And I find that during a didactic, using the chat to share my thoughts in the moment is crucial, as I may not remember it later, and it might be adding context to what the speaker is saying, and I'm not interrupting that speaker. What I found during the case initially was wanting to ask all kinds of questions and offer all kinds of recommendations. And it took some time to realize that I needed to be more concise with my questions and recommendations. But there were times that I felt that what was actually needed was to share my lived experience as either an autistic or a parent to autistics to connect my experience with that of the child that was being presented. And I understand that before my time and before COVID, the ECHO Expert Hub team were all in a room together while the participants either Zoomed or somehow otherwise connected remotely. And so they'd be able to talk amongst themselves in the room with side discussions. But one of the ways we as an expert team worked to adapt to the Zoom world was to create a WhatsApp group for each ECHO that we ran. And this allowed us to chat before and during ECHO sessions to collaborate, figure out which questions or recs might be asked, And for me, it allowed a safe space to vent or sort things out for what may be happening during the session. One of the risks of including autistics in echoes and other learning environments is that the clinical world has not moved from the heavy deficit language of the medical model. Many have been steeped and trained in terminology that is really jarring to hear as an autistic. In each of our echoes, Dr. Penner and I lead a didactic on the language of autism acceptance, where we share concrete examples on what to shift language to and why, and how acceptance is a journey that begins in the clinical experience, and how essential it is for clinicians to move to strengths-based language when it comes to autism. Over the years, we have seen a positive domino effect in the language that clinicians use when they present their cases, questions, and offer recommendations. And it has also changed the language used in many of our own didactics. There can be tough cases, and sometimes I need to go off screen and chat about how it's making me feel. I've always felt heard, and sometimes we end up making it a teachable moment, either during that session or in a follow-up session. We need to make space for autistics to safely feel their experiences. And when we do this, we all grow. Next slide. Many of you have probably heard this. Nothing about us without us. This is the mantra of the disability rights movement, which, in a nutshell, it means that anywhere decisions are being made about people with disabilities, those people with disabilities need to be present at that table. And this includes research. In the autism field, we have had decades of so much research being done to us. So many programs, services, supports, interventions are being done for us. Our parents have been the only voices listened to, and even then, not as experts in autism. I am absolutely grateful for the marked shift that I have seen happening since my oldest child was first diagnosed 22 years ago. And I've seen this happen in much deeper ways in the last 5 years. And this project is a good example of that change. It is absolutely vital that research about autism and autistics includes autistics in the exploratory or the problem definition phase, in the actual research design, and especially in the data collection and analysis phase. One of the ways I have been effective in the research projects that I have been part of is to ask, what is the intended or hoped for outcome? Will this question get us there? Can this wording be changed to be neutral or positive? When we look at so many of the parent-facing questionnaires and surveys that we give parents to fill out about their kids, it is hard, harsh, and depressing. Whatever positives that we may feel will glean from the data in the end are undone by the effect that's left on the parents and their autistic children in the process. Next slide. Building a mindset that conclusions and reports are not just for academics, but also for families and autistics. It means changing the language we use so that we get the effects that we are hoping for, but also do no harm. Having autistics involved in all of these phases can help us to ensure that this research is in fact nothing about us without us. But it is a challenge, however, to engage autistics in research because of the history and the lack of trust many autistics have. And this trust erosion has many sources. The world around us is not designed for autistics. And growing up, we inevitably have been told we need to do this. We've had things changed around us. We've had the world fall apart in front of us and us be blamed for it. And then we look at the research that calls us broken, needing cures or to be fixed, or made to be more employable or more like neurotypicals. The language in most autism research never considered that autistics would be the ones reading it. We are othered and we are treated as objects. It is very difficult to read and turn off the part of my brain that is being hurt by these words. Autistics need to see change over time to believe that change is happening. And starting with autistics on a project as early as possible will have a cascading effect that can lead to being able to engage with autistics at later stages of your research. The work for autistics needs to be meaningful with clear goals, objectives, and deadlines. As our executive functioning may not be our strengths, Having follow-ups to encourage us to finish anything that is on our tasks list can be helpful to some autistics, like me, as Mel quite well knows. One of the challenges that we have had at the beginning stage of this project is having that meaningful work to give our members, as there has been a slow start to the project in other places. There is a lot of waiting on other parts, other sites, other systems, and bureaucracy. Many autistics tend to like things moving quickly when they're working on a project, and it's hard to keep momentum when there are delays to project. So to counter that, it's vital to keep autistics aware as early as possible to set appropriate expectations. Clear, clear and concise communication is the key to being able to adapt for change. Having accommodations available is essential to be able to achieve and sustain engagement with autistics. We tend to be multimodal, so allow for emails or messages to provide feedback than just meetings. If you're doing Zooms, allow the chat function to be used. Don't put us on the spot. Have agendas sent out early as well as slides. And please, 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 please use slides to guide discussion. Many of us need a visual to be able to hear the audio of the discussion. I really personally can't process information at meetings where it is just a bunch of people's faces on a screen with talking and talking and talking and talking. I need a visual to focus my attention. Engaging autistics with lived experience should not just be about checking a box in your grant application. It can't be empty. It can't be token. It must be meaningful. Next slide. So the dream moving forward. What we are doing in the ECHO AuDIO program is baking lived experience into the leadership team and having an autistic council where autistics from each site in the project meets to review the work the project is doing. The council is made up of an autistic person from each site. Each site is already doing an ECHO or is just starting one this year in the case of British Columbia. The hope is that the work we do to improve echoes and measure them can be reviewed by our council, and their experience with the sites or as members of the ECHO teams can be shared two ways. We want to see the successes we experience in Toronto replicated across the country so that we can see an increase in the capacity and confidence in community practitioners to diagnose and support autistic children in their communities. And I look forward to seeing the work and products of every stage be reviewed by our council, and that the autistic lens will be visible to each site's teams as well. The language of the final report gives us an opportunity to use strengths-based language while still appealing to a primarily academic audience. This project is just one project that is stepping into this new way of doing research with and not for and to autistics. Ultimately, by changing how we do research in a truly inclusive way, we will build a world where autistics are involved, are included, are accepted, and are thriving. Now, Manira, it's your turn.
Thanks, Maddie. So yeah, what am I doing here? That's often a thought I have, especially when I'm on a webinar, so I decided to put it here. But also, this building is the Bloorview Kids Rehabilitation Hospital. And to understand what I'm doing here today, I would share a little bit about this thought process that went through my head about 15 years ago. It's a bit of a blur, but at that time, the feeling I had was one of being very overwhelmed. You know, what am I doing here? I am not supposed to be here at this hospital, at this center. I'm not supposed to be here with my kids. This wasn't the plan. And yet we've had many, many visits over to this building over the years, navigating medical and developmental challenges for both of my children. And eventually it was here that we came to the understanding that autism is now very much a part of our lives. Pushing a stroller through slush and snow in the winter, waiting for a bus that came down Bayview every 16 minutes, did that for many years. And I go into that detail because it is recognizing that many community members and families, when they're coming into tertiary care centers, those are the kinds of barriers that they would have to overcome. At the time, I'd walk into this building and many others like it across Toronto, knowing that I needed to downplay some parts of my identity. so that my parent voice could be heard loud and clear, without the inconvenience of needing to factor in who I was as an individual with my many identities. And it's hard to explain that feeling. I often had that, and I still do now, but less frequently. This feeling that I don't belong in the spaces of service that I enter, that I need to diminish some parts of my identity and magnify other parts, namely the English-speaking part, to at least marginally appear as though I have a right to be in these spaces. And it's over many years that I came to understand why I felt that way. I began to understand that these complex systems of healthcare, of education, and social services that we as families must navigate, they were not designed to be accessed by people who perhaps look like me, looked different, or held values and beliefs that were different from regular Canadians. Next slide, please. Regular Canadians. Next slide, please. So what am I doing here now? The systems that families must interact with to navigate autism, the healthcare, education, social services systems, they're very complex. They're a tangled web. And countless families struggle because they're made to feel like the system wasn't built for them, because frankly, it wasn't. Let's just put that out there. It wasn't. A very specific demographic was kept in mind to keep these structures intact in a way that anyone else has been made to feel less than and has been made to feel small. And we know that these systems are being perpetuated to keep those original power hierarchies intact. But it is time for the system to change, to open up and let everyone in. Over the years, I've gotten to know individuals that are driving the organizations they lead to do better. These individuals are committed to creating change while working within the system to create change that breaks down these hierarchies, changes that enable the sharing of power, changes that open the doors to everyone, and changes that ensure everyone has a seat at the table, and that table is round. And so that's the essence of the EDI Council at ECHO AuDIO. Next slide, please. And so who does ECHO Autism benefit? We might talk about the people benefiting being the clinicians in the communities, being the providers that are serving families that are navigating autism. But I think it should be taken one step further to understand that ECHO serves broader communities by empowering community-based clinicians with the knowledge and skills they need to support families that would otherwise have no access. And as Melanie has spoken about earlier, getting an autism diagnosis, it's very challenging, very anxiety-inducing, and it can be a very onerous process even for the most regular of Canadians. But what is this experience like for families that don't fit into that mold? What is this experience like for a family that has roots in the land that are thousands of years old in their heritage and their tradition and their journey, but they're still made to feel like outsiders, that their traditions, their beliefs are not worth honoring? What is this experience of autism diagnosis and assessment and access to service? What does it look like for a family that lives in a remote area where there's very limited access to healthcare, to allied healthcare? The hospital might be really far away. It might be under-resourced. They might have very limited access even to a primary care center, a primary care physician. What is this experience like for a family that's new to the country, where English might not be the first language, where employment is precarious, where there are many social determinants of health that they're navigating, where they might not have a social support system, where employment is precarious, or they might be overqualified and very much underemployed? These families, they feel safe in their communities among people that understand the nuances of their daily lives. And these are the families that ECHO Autism aims to serve. The families that don't have access through conventional existing pathways. Next slide, please. So why is that they don't have access? Where are the gaps that prevent families from accessing autism diagnosis and care? And the issue is that the system and pathways are standardized, as we mentioned, for very much one kind of demographic. But we know that a one-size-fits-all approach cannot really work across the country. Every community has its own identity, its own culture, its own way of doing things, and that is to be honored, which traditionally it hasn't been. And so it's imperative for providers to put in the work to bridge gaps, to take the time to ascertain that their work has long-standing impact and generates positive change for families navigating autism. Providers must put in the work. They must take the time to understand that they have to build trust and relationships before those difficult pathways of autism diagnosis and assessment and access to care can be navigated. It's important for providers to understand the systemic barriers to access that communities can face, from how hard it might be to get to the hospital for appointments, to making sense of all the information that's being shared in a language that's not familiar. Providers must understand the cultural stigma that communities face and that they must overcome before they can even talk about autism. Providers must understand that the values and beliefs of the communities they're serving might be different, but they're just as valuable and just as important. So all of this understanding and trust can only be built at its best form in care that is close to home, in communities that are familiar and that feel safe, in spaces that are easy to access physically and socially. All tertiary care centers, or ivory towers, as Melanie refers to, they'll tell you about the number of families that were lost to follow-up, where families received a diagnosis, but they never came back, or they never even got to the point of diagnosis. Community-based practices will tell you about the families they saw that would have been lost to follow-up had it not been for their practice. And so through the work of the EDI Council at ECHO AuDIO, these are the gaps we're aiming to bridge. This gap in understanding between these ivory towers, these tertiary care centers, and the communities. Next slide, please. And so how do we bridge these gaps? What are community-based clinicians learning to do through ECHO Autism? At least that's the plan. Clinicians are learning to meet families where they're at by understanding that they're not the only experts in the room. Clinicians are the experts in what they went to school for, and parents and caregivers are the expert in their child, and they bring the richness of their own journeys and experiences, right? Providers, they may see themselves as the fixer or the expert in the room, and the truth is, as a parent, I might see them as the same. But if I see them entirely as the expert and the fixer, I'm taking away from my own experience that can contribute to impactful service for my child. And so the onus is on the provider to level that playing field. Clinicians are learning to be mindful of this power differential of giver and receiver, where the clinician is the giver of service and the family is the receiver. And this balance of power is unavoidable, but they are learning to be mindful. Through ECHO Autism, clinicians are also learning to be mindful of cultural perspectives on autism, how it's viewed in different cultures, in different parts of the world, and how does that impact how a family accesses or doesn't access autism assessment, diagnosis, and intervention. It's also important to be aware that some cultures are still working through the post-colonial remnants of their history. That deference to whiteness, the deference to authority figures, it's built into some cultures, and I know it's a part of my own as well. It might be why families might not question, they might not clarify, they might not feel empowered to say what they want or they don't want. And so it's important, the onus is on the providers to create spaces that are safe for families to feel empowered in. And lastly, clinicians are learning to walk in with humility. They're learning to come into spaces from a place of genuine curiosity and continuous learning. And doing that means aiming to understand. It means aiming to avoid judgment. It means being aware and how do I say this? Understanding of their own unconscious biases that they might hold. And they're learning to honor all of the facets of a family's identity and a family's journey. So this is the kind of practice that the EDI Council at ECHO AuDIO aims to see all across the country one day, inshallah. Over to you, Melanie.
I feel like I need a few minutes to compose myself after hearing both of those talks. Thank you both, my beloved truth tellers. I'm so lucky to work with you. So what do we hope that you might take from this? I think with the prevalence of autism being what it is, autism is everyone's business. If you are a clinician, this is in your scope of practice. This is something that you need to be comfortable with. You know, there are also some other things that are everyone's business. You know, walking with people with lived experience, and respecting those voices is everyone's business. Disability rights is everyone's business. Combating colonialism and racism, and other isms in healthcare is everyone's business. You know, my kind of like vanilla sciencey stuff here is that like frameworks help us do this better. And yes, like I would encourage you, if that is your thing, to be mindful of that. But I hope what you really took out of this is that like we cannot design good care without folks at the table who tell us what it's like to receive that care. And specifically folks who have not been invited to the table before. And so that is what I hope you've taken out of this. Hearing Maddie and Manira has inspired me, as always, to be a better clinician, a better scientist. And now I would love to hear, that's what we hope you take from this, but you know, what do you want us to take from you? We are a research team. We have a broad, ambitious agenda to improve autism care in Canada. Engaging a network of families and providers through Children's Healthcare Canada is part of what we are doing to make sure we get to hear more voices about this. So I will end kind of our main agenda piece of this, and I am really happy to hear other folks' thoughts and questions.
I want to thank so much our presenters for today. Maddie, there are heaps of comments in there about your conversation, and not surprising, everyone echoes your key messages there. I want to thank everyone for their feedback on the poll. And while you're responding, I'm just going to share some questions now. Megan has asked, how can support be better accessed in the beginning for referral? Her son's autistic traits weren't obvious to the GPs that he saw when he was younger, and his parents really struggled with certain behaviors at home, but they felt led down several wrong paths by some service providers. How can it be better accessible?
I can start on this one. I think that what we do in ECHO, you know, there's the didactic piece of it where we can tell you about all of the different ways that autism can present. However, I think where this really starts to hit home is when we talk about different cases together. And that's where you can really start to, I think, internalize what these things can look like. And so one of the really common patterns that we can see sometimes is kids who like hold it together during the day and then come home and like explode at nighttime. And, you know, talking through cases together really allows us to get into some of those nuances. I think that's where some of the secret sauce is in terms of really helping people to understand the varieties of ways that autism can present.
And I think that one of the real benefits of the way we do this, it's a multidisciplinary approach. Autism isn't just behavior. Autism isn't just about communication. Autism isn't just sensory. It's a bit about all of them. And I think that depending on when you may have been trained or heard about autism, you may not realize the full breadth of it. And that's, we have the opportunity with the hub team that we have that has the different knowledge in the different aspects of it, plus those of us who are parents and those of us who live that multifaceted autistic experience. We get the opportunity to have community practitioners. For me, it's not just about capacity or competence. It's confidence. It's understanding the full breadth of autism and being more confident to see what's there instead of trying to push it off to a tertiary care place like the Ivory Tower in Toronto for those who are the experts, because the expertise is available.
Thank you. May asks you to comment about overdiagnosis in autism and the role of ECHO.
Yeah, overdiagnosis is a really tricky idea. So one of the things that has been happening is that our understanding of autism has expanded. And I think as a field right now, there's a lot of work going on to try to understand, like, what are the kind of borders of this thing that we're calling autism. There's so much more to learn. There's more to learn about the underlying biologies of autism, because it's not one single thing. How autism interacts with other neurodevelopmental and mental health conditions. And so the idea that there is kind of one singular thing called autism that we're either over or underdiagnosing is kind of a not really a true thing to begin with. One thing I will say is that when we did a study with general pediatricians and we compared their assessments to our multidisciplinary team, there were very few cases where the pediatrician thought the child was autistic and the multidisciplinary team did not. I do think there are other forces at play in our system where autism can be the only diagnosis that gets services that can push people perhaps to make a diagnosis of autism. And that's where we need to reconsider how our service systems are organized so that it's not just dependent on one single diagnosis, and perhaps more dependent on what an individual child's needs are.
Thank you. Suzanne asks, what's the plan to roll this out across Canada?
Thanks, Suzanne. We're rolling. Toronto was sort of the first site, then Edmonton, and then Montreal, and then Halifax. We're hoping to get our BC site going soon. And that's within the study, but as we have been out talking, meeting people, networking, other places in Canada are also joining up. So hello, Saskatchewan, who I believe have recently launched their ECHO program as well. So we're really trying to get this done. And the coolest thing is that our manager, Selena, now runs, I don't want to call it a support group, but like a networking group of all of the different ECHO providers where they can talk about the logistical issues that they're facing, If we have people who are interested in launching an ECHO autism program in their own province or region, we share everything that we've got. You are welcome to our slideshows, our proposals, all of those things. We are eager to help you to get one rolling if that is an interest for you in your area.
We're at time, but there's still a few more questions. Do you folks still have a moment, or can I share the questions with you electronically?
I'm good for a bit.
Okay, me too. Megan asks, will ECHO AuDIO address continued community-based care, and will it extend past grade 4 entry, for example? She then comments about how where she's living, CMS and community-based supports end at the grade 4 entry. But it's a time when kids may even need more supports. And how will they address that?
This is such a good point, Megan. And so there are, like, certainly we our focus, and I guess just based on my kind of location as a healthcare provider has been on how do we support other healthcare providers. That's been our starting point and is sort of our starting point for this project. Now, we have also in our Ontario site started to build out toward how can we take this model and apply it to other groups. So we have run a really successful ECHO as well for psychologists. Again, that has been mostly focused on diagnosis because that is what their role has been. We had run one additionally for therapy providers in Ontario. So we ran one cycle that was for behavior therapists, occupational therapists, speech and language therapists, and mental health professionals. And that was amazing to get to kind of facilitate interdisciplinary practice and let all of these other groups know, here's what your colleagues can do. Here's what your colleague can help with, perhaps if the child is presenting with this thing that we know needs a multidisciplinary approach. I think there's a lot of potential there. There's so much work still to be done. And then there's also the policy piece on this, which is another layer to it, where we need governments to recognize that children and youth and adults need supports as well, and that this is not just a matter of how we support really young children who are autistic, but also how we support them through the lifespan. So I may not have the best answer for that. Maddie's reminding me we also did one with teachers as well, so that kids could receive those neurodivergent affirming approaches in their schools too. No shortage of work to be done.
Your comments align with Fanny's question around how can we support first-line providers if we know it's hard to rule out autism diagnosis in solo practice?
Yeah, this is a big challenge. And I think it speaks, one thing that it says to me is that we need all hands on deck here. And so maybe for those first-line providers, ruling out autism isn't as big of a part of your practice as you thought it was. Maybe diagnosing autism becomes a bigger part of your practice than you thought it was. And those trickier cases where it's hard to make that rule out sort of decision are the ones that need to come and see a subspecialist. And so although my husband frequently accuses me of trying to research my way out of a clinical job, that's really not there's plenty of work for all of us to do. And so I think we need to kind of really just like flip what we've traditionally been doing and encourage people to be providing diagnoses in the community when they feel confident. And when they're kind of in that rule out situation, perhaps the parents have brought their observations that could be consistent with autism, but the evidence doesn't kind of tip you one way or the other. those are the ones that probably do deserve a subspecialist spending a bit more time to figure it out.
You've already addressed Suzanne's question around, is there a plan to bridge the challenge in diagnosis from a pediatric specialist and an MDT? Her comment is, once a parent hears that it's not autism, it's often hard to access help and resources. But the parent knows there's something off or different or concerning to them, but it's not recognized by any clinician. And then where do those families go? And is there an offshoot from ECHO AuDIO?
So from a parent's perspective, as having kids who have not quite met the criteria at one time, but like we knew there were things going on, encouraging parents to be persistent, is one thing. It's important for us to teach clinicians to be open about exploring autism, but to keep a mind open to evaluate things over time, because it's possible that clinically things don't appear to quite mesh. But is it autism? Is it something else? Sometimes it takes a little bit of time for in the family's journey and the kid's journey to see things more clearly, and over time it does. It's one of the reasons why advocacy work, we still need to find ways of, this if you're going to say one thing, I'm going to say this every single time I speak. We need to support the needs of kids and not just the labels, and that involves the whole community. Everybody that's involved in healthcare. We've got to look at what is the need, because the diagnosis doesn't tell you needs, it tells you characteristics, and the needs tell you where you need to provide the supports, the services, and accommodations.
You have my vote. And finally, Emma asks how she can find more about the BC program, or for others programs in their area when it comes out.
Great question. Still TBD. We are working with our partners there. Angie Ip is a wonderful developmental pediatrician out there who's provided tremendous leadership on this. And they're trying to work through some pilot work in terms of how they expand diagnosis to community providers, because they have had some a very structured approach to autism diagnosis. And so we're still working through those details. Hopefully we'll have more to share soon.
Perfect. That's the end of our time together today. I want to thank you all for sharing your time and expertise with us, and in particular, thank you to our speakers today. That said, our audience members joining in, we know how busy you are, so we really appreciate you taking your time out of your day to join us. In the coming weeks and months, we will be hosting a number of future webinars, and in case you missed it, we recently released a Beyond Band-Aids podcast, the pediatric workforce, right-sizing the health human resource system for kids. And you can listen in on your favorite platform for that. In late September, we'll be releasing the next podcast episode in our right-sizing series with Dr. Christine Chambers, right-sizing child health through child health research. More details will be coming towards the end of the month for that. We have an annual conference coming up in October in St. John's, Newfoundland, October 20th to 22nd. It's being co-hosted by our friends at the Janeway Children's Hospital Foundation. And you can save the date for our 25 annual conference taking place in just a few months at the Westin on April 13th to 15th. We have just 6 months to go. It's always great when you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings for these sessions are made available after the fact on our website. Thanks again for joining us today, and thanks to our wonderful speakers for this presentation, the great engagement from our audience members, and hopefully we'll see many of you back here soon. Bye, everyone.